So welcome to our HRI seminar series. So I will start with the land acknowledgement, and I acknowledge that the land that currently we are presenting from, and we live, study, and gather, it's situated on the unceded traditional territory of Claytonette, First Nation, part of the Deke People's Territory, and people that are online, if you would like, please feel free to share the territory that you are joining from. So the HRI seminar series planning committee include Ms. Liana Garaway. She's a HRI manager. And the next one is Dr. Kendra Ferber. She's a faculty member as well. It's me, and we also have a lot of support from Angelina Maximova. And here also is a QR code. If you would like to know more about the HRI seminar series or what's going on and what other seminars or other events we have, you can follow us using that QR code. There's also some paper there if you can take it. I think there is a QR code there as well. So this seminar series wouldn't be possible without the financial and support of the Faculty of Human and Health Sciences, and we would like to appreciate that. So if you're not a member yet, we have a membership portal. It's called HRI Connect. It's good to be a member because you will receive email from us from the events that we have. You also can have a profile showcasing your work, what you're focusing on, also connecting with people with the same topics or area of research, so you can easily find people with the same within the same area. We also have two opportunities. We are looking for 2 students, master's students, to join us as a representative in our HRI Leadership Council. It will be a good experience and a good things to add to your CV. So just saying. We also have the annual general meeting of 2026 on April 21st at 11. You can also scan the QR code, or you can also see it in our HRI website. Please feel free to join us as well. We also have another very exciting presentation. It's a professorial lecture by Professor Sanders. It will not be in the campus. It will be in the Exploration Place on May 11 at 4 p.m. Please feel free to join. I personally feel it will be very exciting because she would like to share her whole career experience with us, which is a very rich experience to be exposed with. I'm looking forward to that presentation. And today we have the honors students presentation. We have 2 students, and they will showcase their work. I will introduce the first one, and we will have her, and then I will introduce the next one. The first speaker is Mrs. Gurkirat Gill. She's a 4th-year student of health science degree. Her supervisor is Dr. Sanja Santaner. She's assistant professor in health sciences department. And the title of the presentation is Examining International Students' Awareness and Utilization of Extended Health Benefits and Insurance. So you can come here, and I will presentation.
Good afternoon. Thank you for the introduction. As she said, my name is Gurkirat, and today I'll be presenting my undergraduate honor thesis titled Examining International Student Awareness and Utilization of Extended Healthcare Benefits. Before I begin, I'd like to respectfully acknowledge that UNBC is located on traditional and unceded territory of Claytonette, on whose land we live, work, and play. This is the outline. I'll briefly go over background, research gap, objectives and framework, and then method, results, and then discussion, and at last conclusion. First, start with background. Canada has a universal healthcare system, but it's mainly designed for its citizen and permanent resident. International students have to navigate public insurance, which is MSP in BC, and private insurance. Most students do not fully understand how the system works. For example, they need a referral for a specialist, and vision and dental is not covered in MSP. Further, language and cultural differences can make this even harder. As a result, when these services are available for students, but they feel confused, delay care, and do not fully understand these benefits. But healthcare challenges are not only about the system, students also face other pressures. For example, international students deal with financial stress, housing, academic pressure. Most of them do not have a family support, so they manage things on their own. Because of this, health is not on their priority list. At the same time, unclear information about MSP, extended healthcare benefit, along with the barriers such as that we all face in our healthcare system, which is long wait time, lack of access of providers, make access even more difficult for them. As a result, many delay care, manage symptoms themselves, or rely on a support from their own country. In addition, experiences with healthcare is not the same across Canada. So as you see, because healthcare coverage for international students vary across provinces, students rely only on private insurances. For example, in Manitoba, they do not have access to even purchase a public healthcare insurance. Like in BC, they can purchase public healthcare insurance by paying $75 per month, same as Ontario. Because of this, researchers from other regions may not apply to Northern BC. So this shows an important research gap. So what exactly is missing in research? First, most researchers focus on journal access, not extended healthcare benefits. There is a limited to no research in Northern BC when it comes to international students, especially on how gap in information affect how students actually use their benefits. Because of these gaps, there is a need for research that focus on not only on access, but also awareness and their lived experiences. And also few studies use intersectionality lens. This study aims to address all these gaps. To address these gaps, the study is designed with the following purposes and objectives. The study looked at awareness and use of health benefit, barrier to access, and how system and identity shape their experiences. The study focused on Northern British Columbia, where geographic and resource limitation can impact their access to care. To better understand this, I used an intersectionality framework. In this framework, access is shaped by overlapping factors such as financial status, language, and social support. These factors work together and influence how students experience care. Now I'll briefly explain how I did the study. This was a qualitative research where I interviewed 9 international students. They were from UNBC and CNC. Interview lasted for 45 minutes to an hour. They're conducted by Microsoft Teams. And I used Braun and Clark thematic analysis with the help of Navivo. Participants were aged from 20 to 29, from diverse program, mostly working while studying, and they had a limited family support, which means that they either didn't had any family in Canada or had a family member in Canada but didn't live with them. Now I'll move on to key findings. The first theme focused on awareness and navigation. Participants described entering the system with limited understanding, which was worsened by fragmented and poorly delivered information. They often expressed that orientation was often overwhelmed or unclear. This made it harder for them to understand and retain the information provided during orientation. For example, one participant said students are like super overwhelmed, bombarded with a lot of information. As a result, they relied on their peers or trial and error method. And one participant explained that I just relied on my friend and did not do my own research. which eventually leads to delayed care. To understand this better, students compared their experiences with their home countries. In their home countries, healthcare was more flexible, faster, easily accessible. For example, one participant said, you can just go and get the medication. Student could directly access providers. They didn't need a referral in their home countries to access specialists. However, access mainly depend on money and connections. Participants who could afford private care experienced faster and better services, while others relied on public systems. For example, if they had a high socioeconomic status, they had more accessibility to healthcare. And if they had low, they would have to rely on public healthcare system, which had long wait times. So while care was quicker, but it was not equal for everyone. When they come to Canada, this creates a strong contrast. Student experience long wait time and complex system, which are system barriers. These delay discourage them from seeking care. For example, one participant said, it will take 2 weeks, so I did not book that appointment. Second, care experiences and communication also influence their engagement. Participants reported mixed interactions with providers. They felt being rushed or not fully heard. Further, communication challenges like it made it harder for them to express their concern, as they felt more comfortable in their native tongue when it comes to expressing concern about their health. So overall, these barriers affect how they use these services. Because of these challenges, students changed their behavior. So few changes in behavior was they delayed their care, managed symptoms themselves, or relied on a provider in their home country, or delayed the care until they visit their home country. These decisions were not only influenced, they were influenced by stress and financial pressure, especially for services like dental and vision, which is not covered under MSP. This shows that access is not just about service, but also about how manageable system feels. Now I will connect all these findings to broader discussion. The issue is not just a lack of information, but how it is delivered. Students relied on trial and error instead of structured guidance. When it comes to healthcare information, there was also a mismatch between their expectations, as their home country had more flexible and rapid access, but Canadian healthcare system is more structured and referral based. Further, the system barriers such as long wait time, provider shortage, complex pathway, which we all know that we have the issues with our healthcare system, made access more challenging for them. This factor lead to delayed confusion, emotional and financial stress. Importantly, these barriers are structural rather than individual barrier. These findings can be understood using intersectionality framework. In this study, immigration status played a central role, as participants were navigating a completely new healthcare system. However, this didn't act alone. It intersected with language, social support, or financial status. For example, students with language barrier found it difficult to communicate their health outcome, which reduces their confidence in seeking care. Financial constraint also played a key role. For services, they were available, but there was gap in coverage, for example, dental and vision, which led to delayed care. Social support further influenced navigation. Students without strong family network relied more on their peers or trial and error method, making the process more difficult. Overall, these findings shows that barriers are not experienced in isolation. Instead, they overlap and reinforce each other, leading to unequal access to healthcare. Finally, I will conclude with some key implications. In conclusion, the study shows that healthcare access is not just shaped by availability, but how well students understand the system. When information is unclear or poorly delivered, students often feel confused and delay care. At the same time, system barrier like wait time, complex pathway, reduced engagement with healthcare system. These challenges are further shaped by factors like language, finances, and social support. To improve access, students emphasize that there's a need for clear, timely, and accessible information through multiple pathways. For example, a recorded video session for how to apply for MSP, or social media interactive engagement when it comes to extended healthcare benefit. So overall, improving how students understand and navigate the system is a key to improve equitable healthcare access. And lastly, I would like to thank my supervisors, Sanja and Chelsea, for their guidance throughout the project. And I would also like to thank the participants who shared their experience and time. And this research wouldn't have been possible without their contribution. Thank you.
Thank you so much for a very interesting topic, and which many of us could relate. And actually using the very important lens that intersection of our identities may shape our unique experiences and health outcomes that sometimes can be missed, that this intersection can be much more important than looking at separate identity that we have, and the intersection can show itself in the outcome. So we can open the floor for questions. And people that are online, you can also raise your hand if you need to ask a question verbally, or you can also write it down. I can read it out loud. And we don't need a microphone here, so I will just activate the salon microphone, so you can just talk and ask a question if you have any question. Any question?
Thanks so much for your presentation and your work. I'm curious about intersections also around different health status, chronic health issues. Was this something you were able to talk with your participants about, and how that shaped their relationship to healthcare access?
I did talk about if they had any medical conditions, but mostly when immigrants come to Canada, they had to have their health checkup done in their countries. So most of them are very healthy and do not have chronic diseases. So I didn't come across anyone who had any chronic diseases and how that impacted their health. Yeah. Yes.
You interviewed people from UMBC and CNC.
Yes.
So I wonder if there's any reflections on differences from either care or knowledge and information from the two different institutions.
So I know that CNC student, they found it more accessible after they got to know about the extended healthcare benefit, because they had an app and they could just look into the app what is covered by entering their certification number. But for UNBC, the students did not know how to access any information about extended healthcare benefits. Even after giving the information that we have extended healthcare benefits, they didn't know how to claim it. So there was no app, or it was not easily accessible for them. So this is the difference which I found. So maybe UNBC needs to look into developing an app for extended healthcare benefits.
I was just wondering, it's kind of related to that
Yes.
question a little bit, but more broadly in terms of, I kind of came in, so I don't know if you discussed this a little earlier, but you're talking about them being able to access the healthcare system itself, but what about accessing supports through the institution, like an app, or I don't know if we have here the International Student Center or the Health Center, how do students find those resources useful, or is the university doing a good at, letting students know that those resources are available?
So students were confused where they could go and ask for help. They did bring up the question that should we go ask international office, or should we go ask health and wellness clinic? So that was the confusion that came up. So there is a gap in education where you can ask information related to healthcare system and how we can navigate. I think that needs to incorporate into orientation session, or a separate session where we can provide them more information about healthcare system. For example, making a session mandatory for international students to attend when they are talking about our healthcare system and how it works, and what are the extended healthcare benefits and what is covered or not. There is certainly a gap when it comes to their awareness about where they can go and ask for help. They weren't sure who they can ask for help, and they never reached out to International Office about MSP or extended healthcare benefit. And one thing which I found that they weren't even aware that they were paying for extended healthcare benefit, which was very interesting. It was included in a tuition fees, but they didn't know what it was for. Yes.
Thanks for your presentation, Gurkharat. I'm wondering if, because we did do the study in northern BC, if, drawing from the interviews or even just like your background literature search in this area, if you were able to like tease out if experiences are more acutely felt here versus, I don't know, more metropolitan cities or.
I think it was similar in other cities because the one research was done in Kamloops. And that was for undergrad student, and they had the similar experience but it was not related to extended healthcare benefit. I wasn't able to find any research that was done on extended healthcare benefit in BC. The research was done more on journal access of healthcare system. And then it was very similar that they didn't get enough information orientation, or they forgot the information. They weren't able to retain the information. They weren't sure how to access help. They didn't know about walk-in clinics at that time when they first came. Yeah. Yes.
We have one question in the chat from Tress. If students had any ongoing health concerns, were they ever able to see the same provider over multiple visits?
So one student did talk about their health concern, that they reached out to UNBC clinic, but they weren't able to see the same provider. And that's why sometimes they felt rushed or felt like they weren't being heard. So they felt that first provider was very responsive and listening to them, but the second provider didn't address those concerns. So they weren't able to see the same provider. I think which is the issue with everyone here who's a Canadian citizen. If you don't have a family doctor, you're not going to have the same provider. You will see a different doctor when you go to a UNBC clinic or walk-in. Well, we don't have walk-in, urgent clinic.
So I don't see any other question online. Do you have any question? I think one last question. Thank you.
Thank you so much.
So we will have our next speaker, Rachel Smith. She's a fourth year health sciences student as well. Her supervisor is Dr. Shannon Freeman. She's a professor at the School of Nursing. So she will present us on experiences of working in long-term care facilities during outbreak of COVID-19 pandemic in Western Canada.
Okay, so hello everyone. As mentioned, my name is Rachel, and I am going to discuss some of the experiences we found that staff had while working through outbreaks of the COVID-19 pandemic in Western Canada, more specifically Northern BC, which is a kind of unique healthcare setting. So first, I'd like to acknowledge that this research was done in this campus on Prince George, which is situated on the unceded and traditional territories of the Lheidli T'enneh First Nations, but we had participants from all across Northern BC, so we just want to acknowledge and respect the nations where they are from. So long-term care facilities during the COVID pandemic, not the best time, just to be clear. Individuals who live in these long-term care facilities often have complex care needs and health morbidities, which make having a virus like COVID that's new, we don't really know how to deal with it, really scary and really hard to deal with. And to put this in a bit of context, at the start of the pandemic in spring 2020, 75% of COVID-related deaths in Canada were in long-term care facilities. So it was a scary place to work, a scary place to live, and a scary place to have loved ones in. And this was primarily due to lapses in governance, delays in policymaking, inadequate staffing, and lack of recent infrastructure like updated HVAC systems that just led to highly transmissible environments in these long-term care facilities. So I did a literature review to see what was out there as far as what staff experienced in Canada during outbreaks, and there's some consistent themes. So there's an increase in workload. Staff were either taking on extra tasks, working longer hours. There was short staffing, which meant less people had more stuff to do. There's a shift in responsibilities because people were just kind of doing whatever they could to help out. There's also a disconnection with residents. Some people or some studies mentioned that you just kind of went back to keeping people alive and you weren't connecting with the residents. Some people who may have been seen as family before, you just went to keeping people alive just to survive these outbreaks. But at the same time, there were stronger relationships between staff, and that's kind of like a trauma bond. They were all united against the goal of beating COVID and to just get through the outbreak. So there's lots of support between staff. And there was this fear of contracting COVID. I don't know if you remember early 2020, we had no idea what was going on, and that was scary to be working in that environment. And you didn't want to be the one to spread it to someone, you didn't want to spread it to your family, you didn't want to spread it throughout the long-term care facility. And all of this caused emotional strain. People were stressed, people were anxious, and it's just a hard time. So I wanted to see, oh, is this like in Northern BC? And is there anything different? So this study is part of a larger multi-method studies focused on capturing the impact of COVID-19 pandemic on those working in Northern BC. So participants took part in semi-structured interviews, which were then transcribed verbatim, and I analyzed those transcripts with thematic analysis to try and identify some key themes. And we were lucky we had people working in all sorts of jobs in these long-term care facilities. We had a bunch of nurses, so that includes RNs, LPNs, care aides, someone in social work, recreation therapists, management, dietitians, a receptionist, and even people working in infectious control. And I had 7 key themes that kind of summarize the experiences of staff working in COVID outbreaks in Northern BC. There was a sense of fear and moral distress. You had to cope with the loss of residents primarily due to COVID-19, and there was an increase in loss of residents. There were shifts in relationships. There were shifts in relationships among staff, between residents, and there was also where people had to isolate themselves from relationships and they kind of lost that support system. There's changes in the workload, both working more hours and taking on new tasks, and there's a lack of support and tools to do the job. There are also things that did make certain people feel very supported in their jobs, and obviously the impact of vaccination for people who had outbreaks post-vaccine rollout. So I'm going to go through a couple of these themes. First of all, staff were afraid to go to work, and they're afraid of getting COVID and infecting their families because you're working in this highly transmissible environment. You're working very closely with people who have COVID-19, and they were afraid of bringing this home to their own families. Some people had their own aged family members. They were caregivers at work and they were caregivers at home. And if they got it at work, then that affected their ability to provide care at home, and they could be harming their family members. So that was a really big burden to carry. There's also staff who feared if they got it and they got sick and they were out for 2 weeks with COVID, how are they going to care for their kids? How are they going to care for their partners? So it was this, I don't want to be the one to spread it, but I also don't want to be taken out by this virus. And then I can't do my job and I can't help those I love. So that was a very hard thing to deal with for people working through outbreaks. Staff also noticed shifts in their relationships with others. As mentioned in my literature review, staff did grow closer together during outbreaks. They were kind of united against this common goal, and everyone who was there, who stayed, they were all chipping in to help get through these outbreaks and to support their team throughout the outbreaks. And many staff referenced having these long-lasting relationships that came from working with their team during the outbreaks. So it was a great time to become closer with staff, but that wasn't necessarily the case with residents. There was less so descriptions of the disconnect with residents and more just having to watch residents go through a very stressful time. Maybe they lacked activities to do, they couldn't see their families, they didn't know why, and sometimes that was taken out on staff. So staff had to manage not only their own stress, but the stress of the residents, and that was hard for them. And because of this fear of spreading it to their families, staff isolated themselves from their families. And though they may have had increased support among coworkers, they didn't necessarily have that when they went home. So staff were isolated, they weren't seeing their kids, they weren't seeing their families because they didn't want to hurt anyone. Well, they wouldn't have hurt them, but they didn't want to spread it and make other people sick. And they just wanted to be able to do their jobs. They had a sense of duty to their jobs, but they didn't want anyone else to have the effect of getting COVID from their jobs. There's also a shift in the roles that staff needed to fulfill. Outbreaks were busy, they were stressful. Some people didn't want to work through outbreaks, so there was staffing issues before COVID, there were staffing issues during COVID, and there are staffing issues outside of COVID in these long-term care facilities, and it was a stressful time. It was busy, especially at the start. We all didn't really know what was going on, so it was stressful, and that's a lot to deal with. But then some people were working longer hours. Some participants described there being no one to take over, nurses who had no nurse to replace them at the end of the day. And they couldn't just leave the long-term care residents alone, so they had to stay longer hours, or they were taking on extra jobs that required them to work longer hours. And staff also took on jobs outside of their traditional job description. The quote on here is from a recreational therapist who kind of stopped doing recreational therapy to support nurses in the hallway to make sure that they had the gear they need and they had help donning and doffing PPE. So people did what they could to help, but it was a really hard job to help with at that time. So why is this important? Why does this research need to be done? It gives voice to the experiences of staff in these long-term care facilities. They worked hard, they worked through a hard time, and they sacrificed a lot. So making sure that we can give voice to those experiences is really important. It also improves our understanding of how to better support staff in future outbreaks. Unfortunately, COVID may not be the last pandemic in our lifetime. So if we can learn from what happened and do better next time, then that's a great thing to do. And it can help us understand current challenges in long-term care. Like I mentioned, we have short staffing in healthcare, and COVID is partly to blame for that. So it helps us go back to the root of that problem and see what we can do better and how we can help people get into these jobs and stay in these jobs and be happy and supported in these jobs. So that's all for me. I would like to thank those who helped me get this research and learn how to do thematic analysis, and of course to the participants who gave up their time and talked about some very challenging experiences that they had. Thank you.
Thanks, Rachel. Very interesting topic, and thanks for walking us through that story, because some of us think that we know what was going on with COVID, but just hearing another news study, we still learn more about what was going on. And one thing that stood to me was that sometimes after the adverse events, we can also have a positive effect out of it. And I love that you also mentioned that positive effect and how it helped nurses to get closer together and work together as well. So do we have any question from the audience? If you also online have a question, you can raise your hand or you can just type it in the chat. But I will start from here. If you have any question, go ahead.
Yeah. So I know that your honors is a fairly short period of time, and I'm not overly familiar with this type of analysis, but I'm just wondering, you had quite a few nurses that you were able to have interviews with, but some of the other allied professions and administrative jobs, you only maybe had one person in that role that you talked to. So again, thinking about if there was any differences that were observed across different roles, or if you guys have any plans to kind of build the study to include more participants in those other.
Yeah, so this is a part of a larger study. So these were people taken from that larger study who had outbreak experience. So there's a bunch of sub-projects among that, some cool work being done. The biggest differences I noticed were between facilities rather than between participants and specific jobs. So it's kind of, because everyone kind of gave up what they were supposed to be doing, other than the nurses, they sort of stuck in their same lane, and everyone kind of took on a bunch of extra jobs. So people were working everywhere and doing a whole whack of things. So it was pretty consistent. It was more so like facility based, where some people had different outbreak experiences. Yes.
Thanks, Rachel. That was well done. I'm curious, you said these were all in Northern BC. Did you have any idea about like comparisons, if like they were done different sized communities, or the like long-term cares were different sized, if anyone had different experiences like based on those?
There were some differences, like in smaller facilities, they may not have been able to as easily isolate people who had COVID. So there was a much higher fear of, we're working with COVID patients and we're working with non-COVID patients, and that spread. But it was looking at where we could find participants in the facilities in Northern BC who had outbreaks. So there's a broad range of places. But yeah, size played a role briefly, but it was kind of also just the community and underlying supports that were there that kind of influenced their experiences.
Actually, we have a kind of similar question from Dr. Bray as well, and she asked that if all the participants were from the Prince George, working in Prince George, or is there any other specific communities in North?
I don't think I can say the specific communities for the sake of privacy, but yeah, it was all over Northern BC. So there were some in Prince George, and some of the long-term care facilities here, but also much more north from here. So all over.
See, people are typing, but I don't see any question yet here. So, yeah.
Yeah, thanks so much for your work. I'm curious a little bit about the forward-thinking aspect of what we might be able to do differently in the future. Thinking, of course, that during every outbreak is a different agent, dealing with different transmission realities, pathways, et cetera. But from your work, what do you see as some of the things that could be done differently, either from a provider point of view or from a management point of view in these facilities?
Yeah, I think one of the issues that stood out was the need for clear and consistent communication to everyone. So making sure that everyone knows what's going on and has the most up-to-date information. Staffing is a big one. I don't think I'm the first person to say that we need more healthcare staff, specifically in Northern BC, but having more people to help out, more people to step in if someone does get sick and can't come to work. So that would be helpful. But it's a lot of just, it's hard. Like a pandemic is hard, especially when you're at the start and you don't know what's going on and you don't have the vaccines yet. So kind of just making sure everyone has the best knowledge that they have the support, they have the PPE, and when the PPE is available, that they have access to the PPE, and just making sure that like those little things are done. And that also there's community support for these people, because at times some of these staff are being blamed for causing the outbreaks. And it's really hard to do your job when you live in a small community and everyone's blaming you for doing this. So yes, that institutional support, but also that community support and maintaining that community support throughout, hopefully not soon, but future pandemics.
We don't have any online question. Do we have any other question here? Thank you. Thanks everyone for being here today, and thanks you, Rachel, as well for the great presentations. And as a supervisor, I'm now much more eager to have bachelor students too. It was amazing research that you did. So I will just finish the session by inviting you to join us for the General Assembly and our professorial lecture of Dr. Carolyn Sanders. So we would love to see you there. Thank you, everyone. Have a good rest of your day.